On the grid. All right. And I know, hey, it's actually have more people than I anticipated. I mean, I know a couple of planned absences, but that's fine. Nevertheless, this is the next lecture unit test material starts now because we did, 3, 9, 11. And so the next one is mostly autonomic and endocrine. I'm not sure what else goes into it. Maybe a little blood. We'll see. Yes, ma'am.
Will you be posting a review video like?
I did.
Oh, you did already? Like, a couple days ago.
I did. Hey, I'm on my game. Tuesday, I did that.
Yeah, you have. You just-
My wife didn't come back till Wednesday. I had all Wednesday to sit in the morning and talk to the machine with the dog, hoping he didn't bark in the middle of it. She's back now, and we're back at work. Oh, now I have all these things to do around the house. Ah, all right. So, may I? Thank you.
Go ahead.
Yeah, yeah, I have permission. I can go. Okay. ANS, autonomic nervous system. So you can call it automatic, you can call it autonomic. I don't care. But this is really the essence in these next couple of chapters. This and endocrine is very much the essence of homeostasis, more than anything else. We talked about it in anatomy. We went over the cranial nerves. There are certain cranial nerves that had parasympathetic activity. There were three. That was all about the eye, the pupillary light reflex. Uh, Seven because of salivary glands, nine because of salivary glands, but 10 because of the vagus nerve is the big player in particularly in the probably more so than anything else in the parasympathetic system. And sympathetic has a lot. It's different. Yeah, I mean, there's dual innervation in a lot of areas, so it's very much a push and pull, type of a situation. And it's that, in a beautifully phrased, they do it in this text, dynamic equilibrium. We're constantly making subtle changes in one direction or the other to maintain this sort of magical thing we call homeostasis. And so, smooth muscles, the heart, glands. I mean, with bones, joints, skeletal muscles, that's all voluntary systems. This is effectively beyond our control. Not beyond that we can't control it. This is where we dedicate a great many medications to. We looked at the neurotransmitter related, some of the activities. Now we try to interact with those substances vis-a-vis medication. Here you're going to see a little bit more. We talk about blood pressure medication and heart medication. A lot of it's going to be here and a lot of overlap in those systems as well. Okay, so optimal shunts blood where needed, really important. Heart rate, blood pressure, digestion, respiration, all the things we don't think about that we control consciously, that we cannot rather control them consciously. Could you control them by meditation or by medication? Yeah, I suppose so. But it's not something that comes that terribly easily. So involuntary, and because it's basically targeting organs and glands, we refer to it as visceral, and it's principally motor. It doesn't preclude the fact that there are sensors there, but it's principally a motor system. And remember the original construct, when you're talking about motor channels that go basically bones, muscles, joints, somatic, and here, autonomic, and it has divided famously into two divisions, sympathetic, which is called the action division, and parasympathetic, sometimes referred to, at least in this textbook, as the rest and digest division. And that's what you all are doing here now, unless you are active. If you were listening to me or watching online and on the treadmill, it might be a little bit different. But for the most part, being relatively sedentary, you're in pretty much full blown parasympathetic activity. So they have their motor fibers, but how they work, the different pathways, the locations of their ganglia, and it's a two nerve circuit anatomically, and what target organ responses to the neurotransmitters they generate. As I mentioned last time, acetylcholine is in most of these. So this is when we start to hear the terms cholinergic and adrenergic. Cholinergic, the neuromuscular junction is effectively a cholinergic, okay, location. because it responds to acetylcholine. But we don't use it for that. We just talk about the neuromuscular junction, whether it's stimulated or not. Here we look at cholinergic fibers, ones that secrete acetylcholine and trigger the second of these two nerve sequences, and sometimes at the end, the release of acetylcholine. Okay, adrenergic is where they release typically epinephrine, norepinephrine, as you will see. So the difference between the parasympathetic nervous system, it starts in the central nervous system, it's myelinated, it's group A. The autonomic nervous system, and we don't use the term pre and postsynaptic like we did in the previous chapter, it's all about the ganglia. And as you will see, the ganglia and the sympathetic are relatively close. They all come out of the spinal cord, and they're relatively close to the spinal cord. It's called the sympathetic chain. And you're going to see in the parasympathetic system, those ganglia are pretty darn close to the end organ itself, to the target organ. And yes, there's exceptions, for sure. So we refer to them as preganglionic. Cell body is somewhere brain or spinal cord, and you'll see they're in both. In particular, again, in the sympathetic, it's spinal cord entirely. In the parasympathetic, it's also called cranial sacral, because the cranial, we've already looked at a little bit. Sacral has a lot to do with genitourinary function. So there's a shared bit with those as well. And you can see a lot of the organs we look at have dual innervation. Not all. That's important. So it's not as fast. They're lightly myelinated. Postganglionic, outside inevitably of the central nervous system, the cell body synapses with the preganglionic axon in what we call an autonomic ganglion, and then it's non-myelinated to wherever it's going. So we're going from fast now with endocrine, we're going slow and slow, comparatively speaking. By no means slow, absolutely, but slower. So again, everything in the somatic motor neurons, acetylcholine, always stimulatory. Here, there's a difference. Every preganglionic fiber, whether it's autonomic, whether it's sympathetic rather, or parasympathetic, they are all cholinergic. They have a great name. They're called nicotinic, the receptors in there, because the substance that we know as nicotine was not originally associated, it was undoubtedly extracted from tobacco, but its origination was not about its addictive aspects vis-a-vis tobacco and other substances. It was used in the laboratory to produce certain changes, and they named the receptors for that. And that's one of the curious things about, and I have more expertise than anybody about nicotine addiction. Okay, it's what they do a lot to you. We'll get onto that more. So they all release acetylcholine. The postganglionic fibers, norepinephrine or acetylcholine, depending on whether it's typically sympathetic or parasympathetic. And it varies. They're not always stimulatory. They can be inhibitory. So, yeah, the higher brain centers are involved. A lot of nerves have both kinds of fibers. There's a lot of adaptive changes. Okay, active muscles require more oxygen and glucose. So autonomic nerves work in concert by increasing heart rate, dilating bronchi, dilating blood vessels, redirecting blood to appropriate areas, constricting some blood vessels, and opening the others. So what you're going to see when you're working out aggressively, you're out for a really significant run, whatever you're going to do, whatever that activity is, you're going to divert resources with regard to blood supply to your heart and skeletal muscle. You're going to open the respiratory channels. That's very significant because that's the easy way to understand what does what and which is which. And you'll see this illustration a couple of times. Myelinated central nervous system, acetylcholine, neuromuscular junction. Sympathetic. There's only two the unique one is here. Almost all of the ganglia are close to the spinal cord, parasympathetic chains. And they're all cholinergic, and they're non-myelinated, and they go to whatever their targets are here. The oddball is this one. So this one, again, lightly myelinated, its ganglia is actually the adrenal medulla. The adrenal gland is the exterior part called the cortex, remember cortex outside the inside, is typical endocrine glandular tissue. It responds to chemical signals and produces chemicals that are released directly in the bloodstream. Definition. The adrenal medulla is probably a misplaced ganglia that happens to be sitting right in the middle of and surrounded by an endocrine gland. And it releases epinephrine and norepinephrine, which even though the names sound similar, they're chemically similar, have subtle differences that impact different structures differently. More on that later and what they do. So, and you've all felt it. That's the prolonged generation of fight or flight. So when that idiot cuts you off and you know he gets into an accident and you're breathing heavy and your heart's pounding and it's oh my God, and you're ready to do something, and frequently if you're like me say things that are inappropriate to the window in the car, advising that person to again perform an anatomically impossible act with himself or a foreign man or herself of their choosing, you know, to copulate with a close family member. See, usually I was going to use bad words. Well, I am not. Farm animal? Copulate? I could have said fornicate. Why the F not? Moving on. And lastly, the one that calms you down almost entirely, parasympathetic, where the ganglia are fairly close to its target. And they are also cholinergic. They produce acetylcholine. It's interesting that there's a subtle name difference where these are nicotinic. This is called muscarinic. More on that later. I know maintenance, functions, energy conservation, activity versus sympathetic. Dual innervation. It's important. Assume that they're all dual innervated and just learn the ones that are not. Okay? That's the easy way. My old saying, memorize exceptions. Kidney only responds to sympathetic because kidney function is based on blood pressure, blood vessels opening and closing. And to that end, the sympathetic is the only one that affects blood vessels directly. Okay, everything else is indirect. Okay, your skin, sympathetic. I mean, so you're going to see there's little areas where there isn't necessarily. You'll see one chart you'll see all the time. So low energy. I live for parasympathetic. Low energy, even while carrying out maintenance. So after you eat something, it's all of those types of things that we're relatively sedentary. You see, oh, why I have to go to the bathroom when you get up in the morning? Because that's its busiest time. That's there. So rest and digest. So blood pressure, heart rate, respiration, relatively low. GI activity, and for that matter, even though you can't detect it, GU activity is relatively high. That's why at a hospital at bedside, one of the things we listen to for a patient is bowel sounds. If they're resting in bed, you should be able to hear little plinks and chinks and clunks and things like that. They're very distinctive with the stethoscope. See, and that's important because if they're not, then we got a problem. Pupils remember we talked about the pupillary light reflex constricted because when you are basically in parasympathetic, it constricts the pupil, and it's all designed about close vision. You're reading a book, that type of stuff. Sympathetic, classic, and the whole ball game to know which is which is to know what happens in fight or flight. Again, the guy cuts you off, something happens, you're threatened. All of those things you can't help it. Okay, so think what happened. Eyes are wide open. You get a dry mouth because saliva would get in the way of respiration. Your bronchial passageways open wide. Your heart's pounding. Okay, you're redirecting blood flow to the heart and skeletal muscles. Your pupils dilate because you're looking far. You're trying to get the big picture. All of that stuff. Your GI and GU, the blood is effectively, other than maintenance levels, bare maintenance levels, shunted to muscles in the heart. That's what it's supposed to do. Okay, those are the kinds of things that occur. Increasing respiration, increasing heart rate, force of contraction, etc. So, exercise, excitement, emergency, even embarrassment, all of those are like that. So, you perspire, but the heat is being but the skin, the vessel's going to the skin. You're going to see that the perspiration is more about cooling the plant, heat generated inside, but the reality is it's not quite the same heat transition as typically we associate with increased blood flow to the skin. Okay, vigorous physical activity with skeletal muscles, heart, bronchioles, and understand that we're going to use up, we talked about that in muscle physiology, we're going to use up that glucose pretty quickly. So I said it before, when it comes to skeletal muscle and liver, that's your emergency store of glycogen. So the liver will undergo or activate glycogenolysis, make it into glucose, and that's your effectively emergency supply. That as soon as the crisis is over, you go back to normal, the glycogen will be resynthesized in the liver and accumulate. It will go into the skeletal muscle and accumulate again for the next emergency, a la the crash car analogy. So it's really interesting. And we all undergo it periodically, all the time. It's interesting to know what's going on. So, parasympathetic fibers, craniosacral, brain, spinal cord, particularly sacral, only sacral. Sympathetic, we call it thoracodorsal or thoracolumbar because it's only in the thoracic and lumbar spinal nerves that protrude. Okay, parasympathetic, important, long preganglionic, short postganglionic. The ganglion is near the target. Sympathetic, the opposite. For the most part, short preganglionic, long postganglionic. So the ganglia, parasympathetic near the organ, or the target, whatever you want to call it, and sympathetic, you'll see the chain. And this is the illustration you see a lot. So take a look at what's going on between the distinctions that are there between sympathetic and para. So here you have sympathetic ganglia. You see this chain that's there. Along the side, they just brought it out. Eye, skin, salivary glands, lung, heart, stomach, pancreas, liver, adrenal gland. That's the adrenal. That's not the adrenal cortex, with the adrenal medulla, bladder, and both of them you see, in fact, the genitals and the bladder. Notice what we don't see here on either side. You don't see kidney because that's when we start talking about blood vessels. Okay, so you notice the absence here, but the presence here, and that has to do with smooth muscle, as you will get to. So you begin to see some of the ones that are the same for the most part, all the ones that you see depicted here, with not a whole lot of changes other than skin only being here, and that's to generate the perspiration. So you can look at all of these chart-wise if you wish, not a big deal. So we start with parasympathetic. Long pre's, short posts, close to or within target organs. Same illustration you saw before. Cell bodies in the brainstem. This is what I talked about with cranial nerves. 3, remember it's 3, 7, 9, 10. Oculomotor, eyes. Pupillary light reflex by way of the ciliary ganglia. That same thing with the pupils. Why we typically have a pen light in a relatively darkened room. We want to see equal and brisk movement of the pupils when light's brought in. They'll constrict when it's pulled away. Same on both sides, whether you come from this side or that side, it doesn't matter. When you see asymmetry, it matters. That's part of the concussion protocol that you hear about so often in sport. And then that accommodation where your pupils will constrict as they sort of point medially following, tip of an eraser. Common test, easiest thing to possibly do. That's the ciliary. Facial nerve. These are basically salivary glands. The theory being, normal function is you're salivating. Whether it's submandibular or sublingual or it's parotid. But in fight or flight, they dry up. That's one of the things. And indeed, we take advantage of knowing this in surgery. What they give you, I do not know what they use today. Part of our protocol was to do a very, very, very famous medicine called atropine. And the other cousin of atropine is scopolamine. Okay, and they base where what we call, and you'll see the terms come here and are important, particularly if you go into the medical field, parasympatholytic. They block parasympathetic pathways. So originally it was used because it would effectively in a slow heart, it would elevate it, but preoperatively, we're less concerned about the heart, more about secretions if you're going to intubate somebody. So standard pre-op orders, they're not changed today in my day and age up till, roughly 2000, last time I operated on anybody in a hospital, was we gave them something for pain, narcotic, some type of antihistaminic substance. So it was typically Demerol and Viscarol in combination because they one potentiated the other, and you gave them some atropine. And we didn't write it. The surgeon, that's anesthesia. They're getting basically the patient semi-gorked on their way to the operating. Now with the advent of propofol, which puts out so quickly, it's changed a little bit. Propofol is almost instantaneous. And the big player here, Vegas. Again, remember my little spiel on that anatomy? Vagus for vagabond. Acetylcholine, originally taken from the vagus and dripped onto heart muscle, taken from a frog, dipped onto the heart, slowed the heart rate down. They call acetylcholine vagus stuffle. Stuff from the vagus. Okay. All thoracic, abdominal, not a lot of alls around. Preganglionic fibers. Okay, wherever I'm not worried about that, but there's one for the heart, one for the lungs. And again, different trunks, stomach, liver, gallbladder, pancreas, small part of the large intestine. Voila. Sacral division. Mostly organs, pelvic, and those getting in, as they're saying, the distal half of the large intestine. So you're looking at ones that are pretty much within not so much the abdominal, but the pelvic area. They branch off with something called splanchnic, which has to do with it. There's splanchnic circulation, which we looked at before, but it's not a term I worry about. And the ganglia are in the pelvic floor, distal half of the large intestine, bladder, ureters, reproductive. So you're going to see these are, for instance, this is the pivotal portion of the nerve that has to do with the sexual arousal. For instance, you're going to see that's the best illustration of they're being used sort of collectively at the same time, but at different stages of the same event. So again, you can see the chart a little bit better. Cranial, you see there's nothing in the middle. Sympathetic's got that handle. Everything else is here. Where it's going, what it's doing throughout the whole area. The sympathetic certainly has a greater degree of complexity. Some structures are only innervated by sympathetic. This is important. The skin portion is sweat glands, perspiration to cool you during fight or flight. What happens in fight or flight? Your hair stands on end, goosebumps, goose flesh, whatever you colloquially call it today. What do we call it today? Oh, you're 20-year-olds. Goosebumps, the movie. Right? And so all of those hair follicles, same thing because your hair's standing on end, and blood vessels. Notice the blood vessel issue is not associated with parasympathetic. So again, learn the exceptions. And because of that, that takes the kidney into concern. Your sympathetic is really what controls flow in, flow out of your kidney. Thoracolumbar, another name for the division, T1 roughly through L2. And remember when you looked at spinal cord anatomy, you had dorsal horns and ventral horns for gray matter. In that area, you had little points pointing out sideways called lateral horns. That's pretty much exclusive to areas where the sympathetic nerves originate. And that, again, T1 through L2 approximately. So voila, same illustration. There's a lot. I don't care about Raymind communicantes. The sympathetic trunk is interesting. They're paravertebral, meaning they're next to it. Years ago, we did a procedure for bad circulation called a sympathectomy. Somebody came in with bad diabetic, older, alcoholic, whatever. And you couldn't feel the pulses in your leg. They're pregangrenous. What they did was a sympathectomy. You go in, incision into the chest, yank out the chain system. it never worked. What theoretically was, if you take that out, the blood vessels, because there's going to be because really most of the stimulation is to constrict, absence of stimulation dilates. Never worked. There was more to it than that, but that was what was done. And we just used to, I hate to say joke about it, but comment about it would be a better way. Every one of those sympathectomy patients, about 6 months later, were doing an amputation. It's awful. So it wasn't, so that was, we now know there were a lot more things that had to do with that. So we began to understand the mechanisms of diabetes, the basis of low and high density lipoproteins, all the things that are common knowledge now. That study about LDLs and HDLs, called the Framingham study, wasn't published until 1980. I was done in my residency in 79. So we didn't, this was all foreign language. We used medicines to control this differently. That's those calcium channel blockers I was telling you. So there's a lot of ganglia. You don't have to know where they are, how much it's anatomical anyway. These little branches going forward and backward are called rami communicantes. And it's basically just networking this chain, and this is what I meant by paravertebral. I mean, you're right there next to the vertebrae that are there. Okay. And there's a variety, I don't go through all that stuff because I'm really more interested in explaining to you how it works and what it does than the anatomy portion, which even though we did not do that in anatomy, I wouldn't continue to do it here. So as you can see, in the parasympathetic, they're typically within the wall of the organ. In the sympathetic trunk, they're beside the spinal cord. And there's a few other ones that are in front of the spinal cord, but not really relevant for us right now. As you can see, there's different ones. So fibers from some of these rami. Sweat glands, erector pili, vascular smooth vessels, pathways via head and thorax. I said there's different ones that go, and you can see where they function. Here, there's that little tip, that lateral horn that you can see there, etc. So, and there's different ganglia. This is called superior cervical, and what it does. Not a big deal, even though it's a branch to the heart. Thoracically, middle inferior cervical ganglia. So, and we can go through chapter and verse of these. Again, once we start getting into abdominal pelvic, we see the term. So if you see the term splanchnic, which I will not include in our test, but somewhere in a test that you're taking for another media, that's, you're looking at abdominal peritoneal cavity. So be aware of it. It's a terminology, which I don't think it is. Abdominal aortic plexus. So this is the old, we used to punch somebody right under here. They called it the solar plexus. You're almost just paralyzed or stopped them, at least temporarily. I realize you're more ultimate fighting and mixed martial arts type of stuff. Is today's variation of, combat sports. We were boxing people. And so that boxing, and that's the science of body punching. Anybody remember a guy named Joe Frazier? Ali Frazier. Down goes Frazier. Down. Late great Howard Cosell saying that. Joe Frazier, Philadelphia guy. I saw his first championship fight at the current Madison Square Garden in 1967 with my dad and a buddy of mine. Watching him fight Buster Mathis, because Muhammad Ali was unable to fight because he was a conscientious objector, and they stripped him of his title. And if you didn't know, I'm familiar with it, Cosell gained a tremendous amount of fame supporting him and eventually clearing his name because he was a conscientious objector. Okay, people just, it's silly. If they bring a fighter, he's not going to be on the combat lines in Vietnam. He's going to be doing USO tours and, boxing against the platoon champ, little kind of like touch football. Are you kidding me? So, but long story short, I remember my dad, my buddy and I wanted to see Buster Mathis, big, tall, very fat for a boxer, like 6'3", 250. And, going up towards, maybe I told you the story before. He's hitting him real fast, punches the head. And he's killing him. My dad said, just wait. So my dad knew a lot of that. He goes, look at all the body punches. Because once his gloves start to drop down to his body, it's done. So by 11th round, they started to drop 9th, 10th, and 11th round. Boom, Frazier, see it. Zipper. Count to 10, knockout. So again, lots of different pathways that are there. So understand these nerves are important because that anecdote's about what they're governing. Types of things, who they synthesize, who they blah, 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 don't care, don't care, don't care. Okay. The only oddball of the preganglionic fibers is the adrenal medulla without synapsing. There's no ganglia. So what that we all basically believe that it's a misplaced sympathetic ganglia. And that when we talk about endocrine function, even though we mention the adrenal medulla, it is much more appropriately part of the sympathetic nervous system. It's just there. Hey, you put it in the wrong place. Get with it. I know, nobody's perfect. I could be in trouble now. So a stimulation, norepinephrine and epinephrine, the old days we called them adrenaline because of their origin and the way they were extracted from the adrenal glands. That was the older terminology. Now we use the name epinephrine and norepinephrine, very similar chemically, slightly different structurally, organic chemistry speaking. Sympathetic ganglia and adrenal medulla arise from the same tissue. Okay. So misplaced. Here it is. Everything is in here. And depending, there are different amounts of that, and they don't work exactly the same as we will see later. And that's important because we've had some big problems over the years with people who were taking over-the-counter medications that were available to the public that led to some deaths. And they were mostly in the form of over-the-counter diet pills. So there's a lot of it dovetails into for years. If you were taking a commercial decongestion, it was called Sudafed. Okay, we don't use that anymore because you can buy large quantities of that, and if you the kind of chemical knowledge you would have, all of you could commercially make amphetamines. And that was the whole thing with Breaking Bad and Speed and all that stuff. Nothing new under the sun about that, but they restricted it. Sudafed was made from ephedrine. That was the parent chemical, which was originally discovered in a particular ephedrine herb from China that had, when it was fine, they knew what it was in China. When it came to this country, we discovered it dilated bronchi and at the same time made people more awake, alert, and suppress their appetite. And so that's where the amphetamines were born. They were ephedrine-based compounds. That's the nugget that's going on there. But they have different acts on different things. And we were using ephedrine-type compounds. The most famous one of these was a GMT called Metabolife. And I have no idea what they were banned, and they came back, and they were banned again. So there are sensory nerves that impact this circuit. And they're more subtle. Chemical changes, stretch receptors, irritation. So when you're getting a stomach ache, it's very non-specific where it is in the gastrointestinal tract, and it changes like this. Is it maybe you're feeling bloated? Maybe it stretched too much. Maybe you ingested something that had an irritating chemical. Just for instance, those are all the things that people sense. Okay. So again, and then the dorsal root ganglia, just the same as any other sensory nerve, they come in here. Okay. And so there's a variety of reflex arcs that are part of it. 2 consecutive nerves in the motor pathway. The afferents, the sensory ones, vary. Because it could be 2 first and second, or first, second, and third order, which again is not important for us. So, and again, you can see an enteric nervous system made up of sensory. You remember we talked about GI tract. A lot of this, the overseer of this is parasympathetic and sympathetic. When sympathetic active, it slows it down. When parasympathetic, like it is now for you, it's active. It's the only reason I explain why everybody leaves the room when I'm talking. It can't be because I'm bored.
No, never.
You do it more than anybody.
No, I don't.
Chelsea told Haley I hadn't heard from her, so immediately she texted me yesterday.
How it works.
That's how I know. Yeah, there's an old saying in life. It works in school. You probably have known this already. It works in life. Never say anything you don't want to have repeated. Never. Could be your best friend. Somebody's hearing it. Never say anything. A lot of us say things purposefully for that reason. You got to be careful with that, and certainly down the road. What are they going to tell me to do? You have to retire. Make my day. Gee, I'll have to stay home. Are you kidding me? Happy dance. I mean, I don't have to work till I'm like 80 years old. Who's going to listen to these old anecdotes? All right. So, the big players here. It's a nervous system. Acetylcholine, norepinephrine. Acetylcholine, same as the motor end plate, same as in the brain. Cholinergic, all. Another one of those all. Autonomic nervous system, preganglionic, sympathetic, and parasympathetic, all parasympathetic posts. Norepinephrine, released by adrenergic fibers at its terminal level from the postganglionic. The only exception, sympathetic postganglionic axons, except sweat glands, and what makes person, so it works again differently. Acetylcholine it'll stimulate sweat glands, which you'll see with the heart. It inhibits heart rate specifically. So, and again, we've coined the terms for that: cholinergic and adrenergic. Why is that important? Because you're going to see and for many of you going into fields where you have either interact directly or indirectly with pharmaceuticals, there's a whole slew of them that are beta adrenergics and alpha 1s, alpha 2s, beta 1s, beta 2s, sympathomimetic, sympatholytic, parasympathetic. And those terms mean if it's sympathomimetic, it mimics the sympathetic. If it's sympatholytic, it blocks the sympathetic, means it will enhance the parasympathetic and vice versa. So a lot of those names, like we're talking about amphetamines, those are sympathomimetic. They mimic the effects. That atropine, that was parasympatholytic. Okay, so particularly its effect was heart rate and drying up secretions. I like that. Those are really important terms. So if you go into a field where you have to know some pharmacology, and many of you are interested in that, be aware of it. So you got it's a whole, everything's another language. Medicine's another language. Veterinary medicine's another language. When I was in podiatry, another language. There's a lot of terminology that's job specific, so to speak. When my wife talks about things she does, crafting and things like that, it's like, really? The only thing we have in common, we both kind of grew up with materials. So we know our way around fabrics and things like that. Yes, sir.
When I used to work at the Samstone Robinson,
Pardon me?
when I used to work at the
Oh, okay.
Samstone Robinson, there was this guy that came in. He always like shoplifted like a ton of Nexium.
Really?
Yeah.
That's crazy. Well, first of all, you can buy Prilosec without a prescription. Okay, Nexium 2, I guess, these days. Those are proton pump blockers. That's what they do. Before Nexium, there was Prilosec. And that was the original one that came out. That works differently. Okay, that's more specific to proton pumps. We talk about, we'll get into that GI wise too.
I think he was making that.
But no, that's really not in that. I might even make it. Originally it was very expensive. I don't think so. If I was there, they have these burgers that are sirloin and prime. They're like sliders. That's what I'm taking. It was a little hard to get 6 gigs. Oh, look, they're on sale. I just take them in the car. I want to see if they're okay. So that same illustration you saw before. Now the nugget about nicotinic and muscarinic. So named after drugs that bind to them and mimic their acetylcholine effects. Remember, nicotinic, muscarinic is the one at the postganglionic parasympathetic. So nicotine, you're familiar with. Muscarine is actually a poison that comes from mushrooms. So if you wonder, from an old smoker, before we take an exam, big exam, I'd be sitting there chain smoking cigarettes to get keyed up. And when the exam was over, you were just spent and you go have a cigarette to relax. Again, it bonds to both pre-ganglionic fibers at the synapses in both sympathetic and parasympathetic. So that's why it was effective. But we're not even talking about the addictive effects and things like that. Mushroom poison, it's I'm not that familiar with muscarine. I'm sure, again, a lot of times before we knew a lot about pharmacology, we would extract things and see their effect in tests back in the 1800s and early 1900s before we really understood that. And again, like I said, be careful if you're going to go out and hunt mushrooms and time is coming, know what the heck you're doing. I'm on a mailing list with the alligator, the Pittsburgh mushroom. I have one here on my Facebook from the Mushroom Society. Go to one of their functions. You know where the Audubon Center is off of Middle Road in Fox Chapel? I forget the name. They have their meetings there. You think I'm elevator, top floor, couple of fries, Happy Meal.
Just because they're crazier doesn't mean you're not.
Right. Well, okay. So all of those types of things. So where are they? Postganglionic neurons, sympathetic and parasympathetic, those because that's what they're receiving the nicotine, as well as in the adrenal medulla, because it's again the acetylcholine is there stimulating the release, obviously the skeletal muscles. It's always stimulatory and it's fast. Remember, when you open ion channels, it's fast, as opposed to that G protein passageways where it's not necessarily as fast. There's a couple of steps. Muscarinic, all effector cells, postganglionic, cholinergic, depends. And the reason it depends, by and large, they're excitatory with the exception of cardiac muscle cells, when it slows the heart rate, whereas it increases GI motility. So the big exceptions so far are the acetylcholine that's released by the sympathetic end cell, okay, at sweat glands, and the big exception is the acetylcholine that works differently on the heart. Which brings us to these guys as we move along. And we're almost done. I'll introduce them. It's a relatively short but very important chapter because when we look at the meds. So the receptors, the adrenergic ones that respond to epinephrine or norepinephrine, when that's released, let's say by the adrenal gland or by another organ, part of that sympathetic at the end of the sympathetic, we classify them as alpha 1s and alpha 2s and beta 1, 2s, and 3s. They're really important. Okay, so it all depends. Norepinephrine at the heart are beta 1 receptors. Increased rate, okay, where epinephrine bronchial relaxation with beta 2s. The original bronchodilators, before we had more advanced ones like Ventolin, that category that most people have, anybody who has asthma, has an agent that works that's a beta 2 stimulant because epinephrine would have other side effects associated with it. But what do we still use for anaphylactic shock? EpiPen. And that's the reason. Not about the heart rate at all, okay, because you might have some degree of impact here. It's all about that. Bronchodilation, very, very rapidly. The usual amount that you find in an EpiPen is 1 to 10,000. Maybe even 1 to 1,000. I might be. I would have. I think it's about 1 to 1,000. And you inject about a half cc subcutaneously, which is the world's easiest injection to give. Whereas subcutaneous injections, all you have to do is pinch up because you're designed to inject it into the fat. I mean, it's not as fast as intramuscular or intravenous, but it's still pretty fast. So what the Humira that I take is effectively a modified EpiPen system. You pinch it up on your thigh, your abdomen, hit the button, and boom, and that's all you have to do. It's really easy. They were just terribly overpriced. And so we still use those for emergencies, and people who have those high allergies like bee stings and nut oils need to carry them with. Some people are just reluctant to do it. Okay, I'll stop you. So we'll stop and we'll pick up at this chart. As you'll see, there's not a lot left in this particular chapter. There's probably the better part of a lecture, maybe 2/3 of a lecture. Okay. So goodbye to everybody out there who's going to listen to this subsequently.